You're listening to The Switch. I'm your host, Stephanie Shaw. Hey, welcome to The Switch. I'm Stephanie Shaw. I'm a multi-certified holistic nutrition coach who, after finding no success with the 18 doctors and 2 world-renowned healthcare facilities I visited, decided I needed to make a switch and take my health into my own hands. Now I'm obsessed with you getting hormonally balanced and emotionally aligned. This podcast is about education, empowerment, and simple no-cost strategies you can implement right now. I'm so excited to be here with you to talk about all things health, beauty, clean living, and mindset. Ready to take your mind and body to the next level? It's time to make the switch. Hey everyone, welcome to another episode of The Switch. I'm excited to be here today with Dr. Shirazi. You know, you guys, I normally only have women on the podcast, but he's kind of slid in. I'm really excited about it because he has some great information for us. A lot of clients and a lot of you guys talk about, headaches that you may be having or issues with sleeping. And Dr. Shirazi is here today to help us get past some of those. So welcome to The Switch. I'm happy to have you here.
Hi, thank you so much for having me. This is fun.
Yeah, tell me a little bit about your background and, let the audience know a little bit about yourself.
Well, I'm a dentist. I'm an acupuncturist. And for about 5 years, I was a sleep technologist. And I have a couple of practices in the Los Angeles area where I focus on helping people get out of chronic pain, typically tension type headaches, migraine type headaches, and treating snoring and sleep apnea as well, both for adults and children.
Awesome. And I was doing a little check-in. You went to an HBCU as well. How was it?
I did. Yeah. I loved it there. Yeah.
So how did that all come to pass?
Well, I wanted to go. So my mom's a dentist. She was the one that inspired me to be a dentist. Mm-hmm. And, I was a dental assistant from the age of 14 to dental school when I was 22. And I was looking for schools. I had enough time to think about it because, my whole family is academia, really. They're all doctors and dentists for the most part. And I became very picky. So now I'm interested in research, but at the time I wasn't interested in research. I wanted more clinical and hands-on. Mm-hmm. And there was really only about 5 schools that really focused on that. It was that all dental school obviously is hands-on and hand-focused, but some more than others, right? So USC was one of them. They were local. And another one was Howard. Mm-hmm. And because they're private, not public, right? Public schools, you have to do a little bit more to give back. And it's the 5th oldest dental school. It's got tremendous heritage. It's 45-minute drive away from the oldest dental school in the United States. And I loved my school. I loved my classmates. The experience was amazing. I still to this day don't understand how anyone wants to live there. Like Washington, D.C., East Coast. Why do people want to live? I don't get it. My father's side of the family is in New York, New Jersey. I mean, I go to visit and it's fun to visit, right? But living there, I mean, I'm so spoiled. I got the weather. People are laid back here. I can't imagine living on the East Coast.
So I live on the East Coast.
What part?
I'm in Ohio. So
Ohio. Well, that's different. That's Midwest.
Well,
come on.
Kind of maybe, but so we're like 5 hours from Manhattan, five and a half hours if you're driving kind of fast from Manhattan. So we still consider ourselves somewhat East Coasters. That makes us a little more cool than Midwest, I think. Well, no, I'm sorry. I shouldn't say that to Midwest folks, but
Ohio is people of Ohio are nowhere near as salty as the people of DC.
True. Very true. We love you. We love you, DC. We love you, New York, New Jersey.
Oh, they'll admit it. Like people in DC, they keep it real. They don't joke. They know what the way it goes.
That is so true. That is so awesome. So I'm ready to dive right in because again, I keep hearing so much from the folks that I work with and from the audience around not being able to sleep. So I know that you help people uncover why they're restless in their sleep. And it's often symptoms caused by sleep apnea. So tell us what that is, what some of the symptoms are.
Okay, well, technically, sleep apnea is classified as two phenomena. One, when you stop breathing for 10 seconds or more in your sleep,
Mhm.
or if you have very shallow breathing, like that
Right.
causes your oxygen to dip 3% or more.
Mhm.
We have different grades. We have like mild, moderate, and severe. Um, and the typical like warning sign is snoring, but not all snorers that snore have sleep apnea, and not all patients with sleep apnea snore. But there is definitely an overlap, right? And when we look at research, of which there isn't a tremendous amount, but when we look at research where they follow uh, people like 20 years after their first diagnosis,
Right.
we find that, let's say in their 20s, if they had snoring and they don't do anything, there's no major lifestyle change, 20 years later, they have mild to moderate sleep apnea.
Oh.
And in their younger days, if they had mild to moderate sleep apnea, 20 years later, they'll have severe sleep apnea. Right.
Hmm.
And something that was very shocking, because people think this is like a fat person disease, that
Right.
you have to be obese. This is
Right.
not true. This is absolutely not true. The obesity and weight gain and edema over the upper pharyngeal airway, of course, will make it worse
Right.
without question.
Right.
And if you don't have it, you can have a mild form of sleep apnea just from being overweight, but it's more of a neuromuscular tone problem.
Wow.
And they even did studies on college aged females with a BMI under 20. So that means they're thin,
Right.
right?
Right.
They did sleep studies on them, and 50% of them were positive for sleep apnea.
Wow.
Yeah.
Wow.
And then women of childbearing age, right? They're estrogen dominant,
Mhm.
are far more sensitive to the severity of the apnea. So, for example, by the way, the way the mild, moderate, and severe scoring came about
Mhm.
was about 30, 40 years ago. Uh, it's a very new profession, by the way, sleep apnea relative to all the other specialties.
Mhm.
Whereas all the other specialties are up to 200 years old,
Right.
sleep apnea is like 30 years old, really, 30, 40 years. It's not old. It's not as common as widespread as it should be.
Okay.
But what they observed was they had patients, they did studies like on 300 people at a time, and they were almost always adult white males.
Mhm.
And what they found was people that had a history of stroke, high blood pressure, diabetes, all of these things, when they did their sleep apnea testing, they had at least 30 or greater. And sometimes they went to over 100, but
Okay.
they had 30 or more episodes per hour. Okay.
Wow.
And so they said, well, we'll just call that severe.
Mhm.
Okay.
Mhm.
And the people, again, adult white males,
Mhm.
that they found to have pre-diabetes, pre-hypertension, depression and anxiety, things like that, they would fall on that 15 to 30 per hour range.
Mm.
And so they called that moderate sleep apnea. And those that basically would just kind of, their only real symptoms was a bit of fatigue and crash at the end of the day, like 4 or 5 o'clock. They need like a Red Bull or a
Right.
coffee to
Right.
reboost. They called that mild,
Okay.
and that was 5 to 15 episodes an hour. So when we finally got around to testing women, we found that women that were postmenopausal were very, very similar to adult white males.
All
But
all women, different races included?
different, I mean, when we start splitting races, it starts changing a bit too. Again, the data is not rich and prolific
Okay.
like it is for adult white males, just being honest. That's just
Right.
the unfortunate reality. But when we look at women of childbearing age
Mhm.
that are estrogen dominant, we find they're far more sensitive to that number. So whereas we consider 5 or less within normal limits
Right.
per hour, uh, women with 4 episodes an hour, it can be associated with migraines, with severe depression, with fibromyalgia. It can be associated with a lot more.
Huh. So I've never thought about that connection. And how do we get people to think about it? Especially when you gave me that 50% number, I'm like, what? It just didn't sound right, because again,
Right.
the assumption is weight, maybe some pre-existing disease. My assumption is male centric as well. That's just, the assumption that I have. So what are some things that people should start looking for so they're more aware that this may be a problem or a concern?
So the best thing to do to look for is to do a sleep study.
Right.
Right. But just having an understanding of the numbers. So it is true that on paper, that men have it worse than women when it comes to their sleep apnea score.
Okay.
Right. But when we factor in that the estrogen level, the women of childbearing age are more sensitive to the lower number, the net result is that we're equal. Right? The severity is equal. There was a very interesting study done out of Cleveland Clinic where they started off with like 1,100 patients, and they did their spouses, like husband and wife, in the same bed, and they did their sleep studies. And obviously it was, both genders had it, but predominantly it was men that had it.
Right.
And what they found that was interesting was the men that were diagnosed with sleep apnea, they had what's called an arousal index of 27 arousals an hour on average. And an arousal is when we go from a deep stage of sleep, like delta or REM, to a lighter stage of sleep, right? And to be honest, that's what causes almost every problem from sleep apnea. It's the arousals, not so much the lack of oxygen. Okay. The disruption in our sleep is the problem, not the sleep apnea. So what they found was the bed partner, i.e. their wives, who did not have sleep apnea, had an arousal of 21 an hour.
Wait, how many what was the men?
The patients with the apnea had 27. And the spouses, and we can say presumably it was from the snoring or the choking or even the silence that was causing the arousal. So they took these 1,100 patients and they whittled it down to 150 that stuck with the CPAP.
Okay.
Right? Because that's a problem with CPAP. Has almost 100% success rate, but a very poor compliance rate. So of the 150 that stuck with the CPAP,
Real quick, I know what that is. Can you tell the audience what CPAP is?
A CPAP is a machine, stands for continuous positive airway pressure, that basically is like a air pressure device that blows air to open up your throat. Like the way you blow up a balloon, it blows up your airway, like your tongue and your throat, so that it doesn't get occluded from your tongue and your throat. And the patients that stuck with the CPAP, they didn't do follow-up sleep studies on the bed partner, but the bed partner reported, oh, my mood has changed. I'm way more laid back. I'm not, my kids tell me I'm much more agreeable. My headaches are gone, and et cetera, and et cetera. So we have thousands of other studies that correlate sleep apnea, clenching of your teeth, TMJ disorders, and tension type and migraine type headaches.
Oh, wow.
So we have that.
Yeah.
Okay. We know it, it's just not mainstream yet.
So so let's say someone's diagnosed and they may not need to go on CPAP. Their number may be really low. What are some more natural ways that they can begin to start to heal their body or to get them in a scenario where their numbers don't get higher?
So your question is, how can someone with sleep apnea not let it get worse?
Yes.
Okay. So, well, first, again, you got to go get tested, right? And you can get tested in your own bed. We have a device called a home sleep study unit. You could do it in your own bed, or you could do it in a lab. If you have more complex issues like that overlap insomnia to your, let's say, sleep apnea, then a lab is preferred because we get more data.
Right.
That's number one. Number two, the most important thing is increasing the neuromuscular tone in the upper airway. So in Australia, there's about a half a dozen studies where patients that learned how to do the didgeridoo, that device, and did the circular breathing that's required to use it, reduced their own apnea by 50%, which is huge. right? There's a technique called myofunctional therapy where they teach you how to swallow, how to position your tongue, and how to use those muscles more efficiently. That technique has reduced sleep apnea by 50% at times as well. So there's other things that you can do. My technique is predominantly using appliances, because even if you do the exercises, eventually you'll stop and it'll come back. Right? It's like you'd have to do the exercises forever and ever, to like keep it there. I guess I just know I'm lazy, so I use an appliance myself.
So when I started like going over the questions that I was going to ask in my mind, I thought, oh, you would say, lose weight or change some different eating habits that you may have, but that does not, as you said before, does not always mean that you're going to have sleep apnea because something else is going on with the body, correct?
Yeah.
Okay.
Yeah. So obviously having the weight and or having edema, because we can have edema like swelling from certain foods.
Right.
Right. MSG is notorious for that. And that will make someone without apnea have apnea. That'll make someone without apnea snore. And that'll take someone with apnea and make it more severe.
So looking for inflammation causing foods can help, or eliminating inflammation causing foods.
Depending on what standpoint, like, so for example, if you've been eating out, like on a daily basis, because the standards of food in America are one of the worst in the world.
Right.
We have one of the poorest standards that are imaginable. So the foods that are created in the fast food market are designed for taste and for addiction, so that you come back and buy it again.
Right.
They're not designed for nutrition and energy. So the consequence is the chemicals, plural, that they put in there can have adverse effects. One, they can be stimulating, right, for if you have insomnia, and two, they can cause a lot of swelling in your tissues.
Before you mentioned headaches. So again, I have clients or folks have mentioned, headaches, migraines. What's the difference between the two, and what are some things that people can do to help overcome those?
Okay, great questions. So tension type headache is when we have the pain, back or front of the head or on the sides, and it's characterized by feels like muscular tension from the outside in. Okay. And we actually know what causes it. It's when the greater occipital or greater orbital nerves are being pinched between the base of the skull and the second cervical vertebra. That's why so many people will have that tension type headache, go see a chiropractor, get their neck adjusted, and instantly their headaches are gone. Right? But the problem is you go back to clenching your teeth, like this. Because when we clench our teeth, we don't just clench this, we clench everything, right? And that throws, most people are, unfortunately, I think, in today's time. And when they do that, they reinitiate the tension type headache. Right. That's why wearing a proper oral device to shut off your ability to clench somewhat, to create space so that your jaw doesn't fall back, that your forces are not that strong, can actually literally cure tension type headache. Yeah. Wow. With migraine type headache, that's what's called a centrally sensitized disorder, which means we have an outside of the brain issue that becomes chronic, and the brain actually goes through plastic changes and causes its own problem. Right? So like trigeminal neuralgias, migraines, those are what we call centrally sensitized disorders. So with migraine, it's associated with the blood vessels, V1 and V2, that they open and contract, and the pain is coming from behind the eye, typically. Usually it's one side, but it can be double-sided. And it's more like the pain is from the inside going out, or the inside going out this way. And that also can be related to a TMJ problem as well, if it's a very, very chronic TMJ disorder, right? But it could also be a neck disorder. It could be a hormone disorder. Could be a gut disorder, and even some emotional challenges can be associated with it.
So is an aura, what's the difference between a migraine and an aura, or are they the same?
Well, they can, you can have a migraine with an aura or without an aura. The
Okay.
aura is a bit more autonomic nervous system intervention part.
Okay.
Right? And so, that's why we say migraines, we can't really ignore them. The medications that we have are really just designed to prolong them, like to push them out, but
Mhm.
they don't really resolve them, the majority of them. There's some new ones that are promising. But for example, like aura has been associated in the female population. So migraine sufferers with aura have been associated with a slightly higher incidence of having stroke later on
Oh, wow.
because of that autonomic nervous system component. So it's always something, you can sometimes have to be your own advocate with
Mhm.
your doctor. You have to let them know what's going on, or her what's going on, and let them do something about it.
Yeah. What are some things that so I'm going in trying to be my own advocate. I don't know what an aura is. I don't even know how to describe it clearly.
Mhm.
What are some things that the audience can do to make sure that they're getting their point across and that they have the right physician in place to help them?
So the first physician you'd want to see with like a headache disorder would be a neurologist,
Mhm.
right?
Right.
And you would want to see if he or she can diagnose it properly and can give you helpful tools to resolve it, right? So I don't have a problem with medication. And it's great. Some medications are curative, right? So, broad spectrum antibiotics cures bacterial pneumonia, right? Insulin prevents death from diabetes, type
Right.
1 diabetes. So we need pharmaceutical drugs.
Mhm.
The majority of pharmaceutical drugs are there for symptom management,
Mhm.
right? And me personally, if I was a migraineur, I would want more than symptom management. I would want symptom management until I found out what was causing it.
Right.
But up until then, once I've discovered it, then I want to treat the problem. I don't want to be on these medications for the rest of my life. So that would be, if that's what your intention is, that's what I would convey to your doctor,
Mhm. Yeah,
right?
I always say that, and you're the customer. So if they
Yeah.
want to keep sticking you on medicine, then do some research, and perhaps you need to find another physician.
And it's not like they have some kind of ulterior motive or they're getting a kickback or anything like that. That's their training.
Yes.
So
Yeah.
if they tell you, I don't have anything more for you,
Hmm.
okay, I don't, if you say, oh, I want to do a sleep study, they should be open to that,
Yeah.
right? But if they say, I don't have anything more, or they don't want to prescribe a sleep study, move on.
Yeah.
Move on. See you
Yeah.
later, alligator. Just move on.
Yeah. Yeah.
Be your own advocate.
Yes, I love hearing that from another physician because I say that quite frequently. If they're not willing to help you, move on. Yeah,
Yeah.
that's so
And you don't have to take it personally. It's
yes,
just that's all they know how to do,
yes, very
you
true.
know? So you just have to ask
Yeah, that's true.
and
And
see where they're at.
yeah, and some will actually tell you that I don't know what else to do.
Yeah.
So coming in, making yourself aware of what's going on and doing a little bit of research, and don't live on WebMD, but doing a little bit of research on your own could be helpful as you're working with your doctor to get the information that you need. You
Yeah.
also mentioned that there could be some type of hormone imbalance, or maybe we talked about this before the podcast started, you guys.
Mhm.
But some type of hormone imbalance as it relates to headaches and or migraines.
Right.
Talk to us a little bit about that.
So if we have, it's called menstrual migraine. If we have the typical migraine, the menstrual migraine that comes on about a day before their period starts,
Mhm.
I would want, if it was my wife, I would want them to work with an endocrinologist that understands uh, what to look for in estrogen progesterone ratio. Okay. The amount of estrogen, the amount of progesterone is not as important as the ratio. Okay. And of course, we need to understand thyroid function because thyroid function precedes what the hormones do. So we would want to work with an endocrinologist that understands that. I have yet to meet an endocrinologist that understands that. So I've worked with naturopaths, like a licensed naturopath. They seem to understand that way better. Yeah. Like it wouldn't, if you ask them to do that, to look into that, that would not throw them a curveball.
Not at all. Not at all.
And they can, and they're also licensed to do bioidentical hormones.
Right.
So, but it's custom. So the few physicians I know that will attempt to work on the estrogen progesterone ratio, one, they haven't looked at the thyroid, and two, they kind of put the patient into one of four categories, and then they just pick that category and that's what they do for them. And it works about 3/4 of the time, I think. But with a naturopath, everything is custom made. They do the blood work, and they have to do the blood work at different days of your cycle, right, to find out what the picture is, what your body's doing, and then respond to that.
I want folks to hear exactly what you said, that you can't just do the blood work one time. You have to work with someone that clearly understands that there is sometimes a long process in order to get you healed, but the outcome becomes you're like not on any type of medication anymore. It's proactive in helping you, so you're not, the onset of disease is less likely. I think it's an awesome alternative. I appreciate you saying that.
Yeah, absolutely. Yeah.
So you have a section on your website that's devoted to nutrition. Tell us why you have that there and how people can glean from that.
Well, obviously, nutrition is very important, and not just for energy, but for gut health. Okay. So the motto of naturopaths, as we were talking about before, their motto is first heal the gut. Right. And it's very funny, like they'll do case studies and the person will have hormonal issues, psychological issues, joint issues, skin issues, and they'll ask the class, what do you do first? Check the gut. Right. And they would be accurate at least 80% of the time. Okay. Because the gut is so important for every single function that we do. And when our gut is being irritated by poor nutrition and food that the body finds abhorrent or toxic, that can have an effect that affects every aspect of our lives, every aspect of our life. So nutrition, so there's things that we need to know. So like when we have those numbers, the FDA, like minimum, or the daily allowance. So those numbers were achieved largely by testing on animals and finding out what's the minimum amount of that vitamin that animal needed to not die. Okay. Not to thrive.
Not to thrive.
Okay? To not die. Okay. Yeah. And then they're like, oh, well, that dog was 25 pounds. Average human is 150. So times 6, and that's your daily recommended dosage. Right. So it's not, that's why sometimes you'll look at the bottle and it'll say 5,366% of the daily recommended dosage. It's not because you're overdoing it. It's because most people aren't getting enough.
Yeah.
And our food is compromised. Our farming is compromised. Our soil is compromised.
Big time. Yeah. Yeah.
So we do live in an age where we have to supplement.
Yeah, we do. We do. A lot of people don't like to hear that, but you do. And I always tell people, do not go to the corner drugstore and get the 500 capsules for $3.99 either.
Yeah. You're just getting pretty urine.
Yeah, exactly. It will glow for you, but yeah, make sure that you're getting good supplements and working with a naturopath or someone who really knows their stuff. So
that's right.
Yeah. Yep. So perfect. Thank you so much. I so enjoyed this conversation. I like getting into the weeds and knowing a little bit more about how we can support the folks that listen. I have two more questions for you. I like for everyone to leave us with a bit of advice, something free that people can walk away with immediately and implement. And then the last question would be, what is your switch? What made you the person that you are today?
Okay. So in the context of sleep, I talk about sleep hygiene. So that means having a bedroom that's very, very dark,
Mhm.
that's as free of electronic equipment as possible. So I don't have a television in my bedroom. Um, I try to keep my head away from electrical outlets. And I always put my phone on airplane mode when I sleep.
Mm.
The bedroom is limited to sleeping and sex only.
Mhm.
There's no eating, there's no family time, there's no arguments. It's for sleeping and sex only.
Mm.
And it needs to be a cool environment. So that those are very, very conducive to sleep.
Right.
And also because again, the day of technology and the iPhone and and the iPads and everything, all of these, they have blue blocker glasses
Right.
that I recommend people wear when it's dark outside
Oh.
to let the brain know that it is nighttime,
Hmm.
because the brain, our circadian rhythm is modulated by our eyeballs and
Right.
how much photon of light it absorbs. So the brain can't tell the difference between a photon of light from a screen or a photon of light from the sun. So
Oh.
wearing a blue blocker helps the circadian rhythm know that it's nighttime.
Mm. I never heard that one. I love when I learn something new.
Yeah.
Awesome.
Um, and the thing that changed it for me was, and it's going to sound very, very simple, but it's that nothing has any meaning whatsoever until you give it one,
Ooh.
right? That means everything, absolutely everything without exception is a neutral event until we decide it's a good thing or a bad thing. Yeah. And it doesn't mean what we want and what we don't want, right? That always exists, right? But like in my lectures, I talk about, and I share this with my patients as well, that in Hong Kong, it's considered polite to burp at the dinner table, right? Because it means you ate the food so fast, you got air in your stomach, and then you had to burp, right? It's such a well known thing
Right.
that people will fake burp at the dinner table to let the mom know that the food was yummy,
Wow.
right? Now, in the West, we consider that rude and disgusting to burp at the dinner table, right? So if we take the meta position, we can conclude that burping at the dinner table doesn't carry an intrinsic meaning.
Mm.
It's neutral until we colloquially agree that it means this or that.
Yeah.
And then if we take every religion on the planet, every human being on the planet, we can say that there's 2 billion people, roughly 2 billion people,
Mhm.
that think that eating pork and shrimp is dirty and sinful,
Mhm.
right?
Mhm.
And right next to those 2 billion people, there's about 1 billion people that say, well, pork and shrimp is fine, but you can't eat cows, right? And, you know, there's another 3.5 billion people that say, well, you can eat any animal you want, just not on certain days of the year, right?
Yeah.
And there's between a half and 1 billion people that say that you shouldn't eat any animal, right?
Mhm.
So again, we take that meta position, we can conclude that eating or not eating any animal any day of the year doesn't carry an intrinsic meaning, other than you can say you are technically, most of the time you are
Right.
technically killing it.
Right.
Right, you're
Right.
taking its life in order to feed your belly. But you have to understand, people took these beliefs and thought it justified wars,
Yeah.
right? So just having the awareness that this doesn't have to mean what I used to think it means,
Mhm.
right? And the arrogance that I used to have in knowing what the other person meant. Do you know what I mean? And their intentions, right? Sometimes I was right, but there are other times where I just don't know. So why get upset about it? It's my choice to be upset or not.
Right. Right.
So that was big for me.
That's huge for me. I like that. I
Hmm.
like that a lot. Nothing has meaning until you give it one. Yes.
Absolutely nothing does. Yeah.
Yeah. Dr. Shirazi, this has been amazing. I thank you so much for your time. And I know that the audience has learned so much from you.
I hope so. And thank you for your amazing questions. You asked some really great questions.
Well, thank you. Thank you so much. And everyone, here's to your health. I am so excited for you because you just finished another episode of The Switch, which means you are the fierce person I already knew you were. If you're ready to join an exclusive group of other fierce high performers like you, a group where you can bounce ideas off one another and ask questions, be sure to join our exclusive Facebook community. You can find the link below.